have been able to bring two of our most promising programs into clinical development and to patients in areas of our programs have clear and distinct first-in-class potential, and we're confident that following the initiation of phase 2 in sarcoidosis, along with its potential to expand into other indications, we will be able to partner OATD01 for the second time. In the early pipeline, in the immuno-oncology part of the pipeline, we have OATD02 that has been cleared to start phase 1 development in solid tumors, and it will be the first drug developed in Poland that has first-in-class disease-modifying potential that will be dosed to Polish patients in 3 different centers where patients are already lining up for the screening process. So we will start. Maybe next slide already. We'll start our discussion today with OATD01 and its potential to provide a disease-modifying treatment to patients with sarcoidosis. Following the regaining of rights to D01 from Galapagos, we have reviewed a complete set of documentation received from our former partner, including the scientific and pre-IND advice from EMA and FDA. And we are on track to submitting the IND to the orphan drug section of the FDA in the first quarter of next year. We're in the final process of selecting an international CRO that will manage this trial of about 80 to 100 patients in 20 to 30 centers worldwide, with the endpoints expected by mid-2024. I will now like to turn the microphone over to Zbyszek, who will talk more about the science of chitinase.
Thank you very much, Marcin. Yeah, so let me
Bardzo
first
dziękuję.
explain a little bit more about the target that we pursue. This is a chitotriosidase 1, KITE1, and it is known, a body of literature has shown its function in the immune response and the associated inflammation with the disease states. So one of the first things that we wanted to do in the company to look exactly at the expression of that protein and how it's changed in the disease states. Importantly, as you can appreciate on that photo, you can see lungs of a healthy individual where there is no KITE1 expression under steady-state homeostatic conditions. Here, an example of IPF. So you first of all see the change of the structure of the lungs, but also expression of our target protein. After further analysis, we identified macrophages, immune cells, innate immune cells in the lung as the ones that bury that protein, that gene, and express it. And this is very important because this is a target cell for our compound, and as I will show in the next slides, it also affects our way of treatment. In another disease, lung sarcoidosis, which Samson will go more into the details, we see a very similar situation. We see the changes that are granuloma formation in the lung of patients and a high expression of our target protein. In healthy parts of the lungs, you cannot really see any of that expression, and that's another information for us that another inflammatory/fibrosis state is accompanied by high expression of our target protein. We wanted to specify further where exactly our protein is located, which will then help us to understand biology of it. And we have used big data sets of omics, the RNA-seq data by professor in United States, Naftali Kamiński, we have identified the expression of our target gene in subpopulation of macrophages. So as you can appreciate here on the slide, the KITE1 expression is present in the macrophages, which is absent in healthy donors, but activated in the fibrotic states. That pieces of information further justify targeting that protein in inflammatory diseases. Now, I would like to explain a little bit more about the mechanism of action of KITE1 and how we think about it in our research. So the KITE1 is important for the accumulation of profibrotic macrophages. So it's important when these cells in the lung with the detrimental phenotype, they either come from the vessels, there is an influx of monocytes that then differentiate into the macrophages, which KITE1 participates in, or regular macrophages, which actually in the lung have anti-inflammatory phenotype, they turn into profibrotic macrophages within the KITE1 action. Macrophages, which are important for the initiation of inflammation in these disorders, have a constant crosstalk with a resting fibroblast, an effector cell in disease states such as fibrosis. This crosstalk, which is mediated by KITE1, release KITE1, activates fibroblast into an invasive form of it, a myofibroblast, which then produces extensive amount of collagen and causes extracellular matrix remodeling, and then the changes that I have shown you on histology are present in the lung. So this is a constant feedback loop, and by inhibiting of KITE1 and acting on macrophages, we not only stop inflammatory response, but also affect further downstream fibrotic disorders. So in other words, the fibrosis is an uncontrolled inflammation, uncontrolled chronic inflammation when it cannot be stopped, and our drug is affecting that process by inhibition of KITE1 and these processes that I just highlighted here. And this is in many different disorders present, which I will go over the next slides. First of all, importantly from the clinical perspective, is the fact that KITE1 is a known biomarker for various disorders, such as IPF and specifically sarcoidosis. It's present in the serum, which represents systemic inflammatory changes, but also localized in these diseases into the sputum or bronchoalveolar lavage fluid. Now, with the help of genetically modified animals, we lacking KITE1 expression, we have proved that both inflammation and pulmonary fibrosis is attenuated in these animals. So the endogenous expression of that protein has function that results in pro-inflammatory and pro-fibrotic character of it in animal model. That gave us more confidence to go to the experimental and preclinical setup with these disorders. Now let me introduce a little bit more the OATD01, so the KITE1 inhibitor. I would like to start with an introduction of it and how it works in a model of sarcoidosis, a model that involves multi-wall carbon nanotubes. This is a model in which nanotubes are introduced into the lungs of animals and then phagocytosed by macrophages. Macrophages that try to eat up these tubes, but they fail, and that's how inflammation is caused. So macrophages that are in the center of that inflammation, just like in the granulomas in the patients, are then surrounded by other inflammatory cells, and granuloma formation takes place. So we have performed that model We have specified KITE1 expression in the macrophages, and the granuloma formation was identified. An addition of our compound OATD01 inhibited the granuloma structure formation, but also a chemokine CCL4, which drives further the inflammatory process and recruitment of adaptive immunity such as T cells and whole inflammatory cascade. All these features were inhibited by our compound. We went on and tried to study the fibrotic element of KITE1 activity in a model of bleomycin-induced lung fibrosis. As you can see here on the histology sections, the control lungs look quite nice. Alveolar space are perfectly normal. The bleomycin is a drug that is inducing fibrosis, and you can see extensive collagen deposition in the extracellular space and other features of fibrosis of the lung. Our compound at the dose of 30 milligrams per kilogram given BID inhibited and not only inhibited but reversed these features similarly to pirfenidone, which is used here but much higher concentration. And below you can see the quantification of what I just described you. Another organ which is also prone to some chronic inflammatory states followed by fibrosis is the liver. And a NASH is now a well-known disease with unmet medical need. We have tried our compound, assuming that the processes that we studied in the lab would also hold in other organs. And indeed, in mice and rats, in different models, we have proved efficacy of our compound. Which was very reassuring and exciting. Some of data comes from our lab, some of data comes from our colleagues from Galapagos or CROs, so it was proven in different places. And these experiments are specifically important for me because our former partners in Galapagos performed the RNA-seq data. RNA-seq data on experiment in NASH where our compound showed efficacy, which give highlights of the mechanism of action of OATD01. So first of all, the most upregulated processes in these diseases were involving macrophage migration and also other immune responses of myeloid cells of origin, which proves that our target cells play a crucial role in that disease state. Actually, one of the most downregulated pathways involve the metabolism, which makes sense when you learn more about the origins of NASH. Our compound, in a very clear and strong from statistics perspective view, because these experiments were performed on 10 animals and results were very consistent, so we believe for the value of it, our compound changed the metabolism of the liver and induced anti-inflammatory processes which depend more on the mitochondrial phosphorylative oxidations, and this resulted in the downregulation of collagen production and extracellular matrix organization. So all these features that are associated with the NASH disease. As you can see here, the processes that were most upregulated in a disease were mostly downregulated by our compound, which shows how specifically it works. And these diagrams below prove it, that basically all the most dysregulated genes by the disease were then changed back by our compound, showing how effective and specific it is. So to summarize the action of OATD01, we are having a potent agent that works in the nanomolar concentration, and it is efficient in inhibition of chronic inflammatory states leading to fibrotic disorders. And we with optimized drug-like properties, it is possible to give it once a day as a tablet for an oral use. And now I would like to hand over to Samson, our CMO.
Yes, I have the pleasure to present you some of the clinical data and the clinical aspects that drive our program. This slide depicts a summary of what are the requirements from the scientific but also regulatory side to move OATD01 into further clinical development in patients. So first, we have compelling data. We have a proven efficacy in animal models of sarcoidosis. That's our choice of indication for the further development. In chronic and acute asthma, in idiopathic pulmonary fibrosis, which was partially done by our former collaboration partner Galapagos, and in non-alcoholic steatohepatitis. There are compelling translational data. There is an excellent pharmacological profile, which is quite a requirement on the clinical side. There is a demonstrated safety in animals and in healthy volunteers, in human healthy volunteers. Phase 1 studies in 4 phase 1 studies have been conducted in human volunteers, 2 of them dosing studies and 2 drug-drug interaction studies by our partner Galapagos. Overall, 129 human subjects have been exposed to OATD01. With respect to the regulatory side, we have achieved orphan drug designation for IPF and sarcoidosis in the United States. 2 scientific advice meetings were conducted, one with the FDA as a pre-IND meeting, and one with the EMA, the European Medicines Agency for the European Union. Next slide, please. A panel of international experts from Europe and the United States, and of course from Poland, I will come to Professor Grenke in a moment, is very supportive of our program. And they have also given significant advice to our upcoming phase 2 studies that we plan to be conducted in the United States and in Europe. So amongst these were from the Netherlands, Dr. Wesenbeck, from Germany, Professor Kreuter, from France, Professor Cotin, and of course from the US, Dr. Culver, who is also very active in the Foundation of Sarcoidosis Research in the United States, and Professor Judson from the Albany Medical College. All of them very well known and long-term experts in their respective fields, and they are very supportive to us. I would also like to mention again Professor Grenke, whom I will introduce in a moment. Next slide, please. Now, coming back to the summary, and I would like to depict some of the key issues that we have seen here. There is quite a strong correlation between KITE-1 activity with the disease process. We find a 10 to 100-fold elevated KITE-1 activity in serum, but even more so important in the bronchoalveolar liquid in sarcoidosis patients. This correlation is between the product and the clinical stage, as well as the progression of the disease, which means as the disease progresses, the activity of the respective enzyme is increasing. That's why KITE-1 is considered the best marker of disease progression. Now coming to the disease of sarcoidosis, there is a high unmet medical need. For more than 30 years, no significant new drug has been approved for use in that indication. There are quite a few drugs, but they are used without basically a registration. So the standard of care is corticosteroids, an active compound, but associated with significant long-term and mid-term side effects that often drive the patients to get to a second-line treatment, which is immunosuppressants, not mentioned here. These immunosuppressants obviously are used to reduce the dose of the steroids, but sometimes they are also given as a single agent. In general, the disease may progress further, and then as third-line anti-TNF-alpha monoclonal antibodies are being used, such as infliximab or the like. These are moderately effective and are also associated with a significant toxicity burden and obviously also a cost burden. Now coming to our clinical phase 1 results, why are they so important? They show a full and sustained pharmacodynamic effect with our compound, OATD-01. They have been demonstrated to reduce the baseline chitinolytic activity in plasma to 10% or even lower. The observed PK and PK/PD effects and as well as the safety in those subjects justify further clinical development. Next one. Coming back to the phase 1 studies, we conducted 2 clinical phase 1 studies. One is with a single dose, single ascending doses with the range of 25 up to 600 milligrams. There was another phase 1 study with a multiple ascending dose of 25 and 50 milligrams for up to 12 days. As a result, OATD-01 was generally very well tolerated. There were no SAEs, no serious adverse events. There were no alerting safety observations that would prevent us from going further into the clinical development. The steady state was reached at about 25 in both 25 and 50 milligram doses with nearly complete inhibition of the chitinolytic activity in plasma in the multiple ascending dose study. And through the dose predictions based on the PK and PD modeling, we could see that the target engagement in the lungs should be observed at doses between 15 and 25 milligrams. And 25 milligrams is the dose that we will put forward to our phase 2 study. Now, during the partnership with Galapagos, they had targeted idiopathic pulmonary fibrosis as their primary indication, which is why they conducted 2 drug-drug interaction studies using products that are generally often used in that indication, like pirfenidone, nintedanib, and midazolam. And all those 3 testings did not show any adverse effects that would prevent us to go forward. More importantly, we have seen that the application of our drug in patients that had food slightly decreased the absorption rate. However, it did not impact on the bioavailability of OATD-01, a very important feature for drugs that are given orally. Next slide, please. Now, I would like to present to you our planned phase 2 study to start in 2023. This will be a double-blind, randomized, placebo-controlled, multi-center study, and the endpoint is obviously safety and efficacy, primarily efficacy, with our drug given as a tablet for patients with active pulmonary sarcoidosis. There is a range of endpoints that we use. Foremost, it's an imaging response by PET-CT taken at screening after 12 weeks of treatment. And the aim is to demonstrate the reduction of granuloma formation in the pulmonary parenchyma. That's quite innovative endpoint. It is is currently being used in many sarcoidosis studies, and we are in discussions we'll be in discussions with the authorities to make this as a primary endpoint. Then, of course, there is the difference in pulmonary function. That's a typical clinical endpoint. Then there is the number of patients escaping to corticosteroids that we will map. We will also map the change in the quality of life between patients that have OATD01 and placebo. And naturally, safety is a very important aspect, as well as we will map and eventually be able to validate our biomarker, the KIT1 activity. Around 80 to 100 patients, currently we plan for about 90 patients will be included in the study. And the study will take place in 20 to 30 sites in the US and in the EU. Now, sarcoidosis is, of course, not the only disease where fibrosis does play a role, as you have already heard from Spišek and Marcin. This will, if proven successful, this will be the opening of the ATD01 use for other indications where chronic inflammation, tissue remodeling, and fibrosis does play a role. For the lung, that would be pulmonary fibrosis, obviously, and other interstitial lung diseases. For the liver, that would be NASH, non-alcoholic steatohepatitis, a very common disease, and liver fibrosis. Now it's my honor and my pleasure to introduce Professor Kränke. He is our important advisor in Poland, and he has collaborating with the company for a very long time. And he has had a lot of more than 125 original papers, 60 review papers that partially have also been in collaboration with Molecure. He is currently the head of the Department of Internal Medicine and Pulmonary Diseases and Allergy at the Medical University of Warsaw. And his major scientific interest is focused on obstructive pulmonary diseases and pulmonary infections. And as he is also a member of the European Respiratory Society, and we are really proud that he is supporting our program. So, Professor Kränke.
Thank you, and good day to everyone. As announced, I'm going to discuss some sarcoidosis issues from the clinician perspectives, and my slides have been prepared in English, but I will speak Polish, and I hope this will not affect your ability to follow the data I'm going to present. Sarkoidoza jest chorobą
Sarcoidosis is a multi-organ disease. Its nature consists in formulation of granulomas that I have shown on the right side with a pink, intense pink color. We have normal alveolar elements, and however, there are serious consequences in the disease as fibrosis. It is not explained why sarcoidosis shows a predilection for lungs, for respiratory system, but 90% of sarcoidosis concerns and involves lungs. It is classified as a rare disease, but if we look at epidemiological data, which is shown in the next point, you can see a large incidence, especially in Northern Europe. It is one of the largest incidences noted. Also, you can see between 1.3 to 14.8 persons affected per 100 inhabitants. This is the incidence. However, the prevalence is higher, and it is between 60 to 77 patients per 100,000. So in 1 million cysti, we have several hundreds of such patients. So the risk of sarcoidosis in the population among of Black Americans is 2 to 3 times higher than in white Caucasian population. So it is there is a lifetime risk of 0.85% in this population. This is the data that you may not see very clearly in the table, but what I try to do is to sum up every data that concerns all types of organs. First of all, it is lungs, an organ which is indispensable for living, but also we have eyes affected, we have skin, we have kidneys affected. So we can see that many organs can be affected.
Usually in lung diseases you use certain degree of advancement, and we recognize that at different levels of advancement. And here I give you examples of the stages 1 to 4, describing on the right hand side what it means and what symptoms are presented in patients. And this is very significant for identifying the course of the disease, because the opportunities for spontaneous remission is higher in stages 1 and 2 than in stages 3 and 4. And in this slide, I would like to present the level of destruction of the system. On the left-hand side, you have the correct cross-section. On the right-hand side, you can see a mesh of white patches. These are the fibrotic changes in patients with sarcoidosis. And that that was as regards the respiratory system, but we also have images in other organs, such as the brain, heart, or another part of the central nervous system that is and all that is very important for the life of patients and for the progress of the disease. The problem in sarcoidosis, which is not really a very rare disease as we might infer, because we may have several dozen patients only in our centers, and then decision which to treat and which not to treat, and hope for spontaneous remissions, because this remission occurs in 60 to 80% or absence of progression, but only in 30% can hope for such developments if they already reach stages 2 and 3. So they are ideal candidates for further treatment. And what it looks like across the lifetime in patients with sarcoidosis. I would like to remind you first of all, what are the proportions and degrees of advancement at the moment of diagnosis. So half already have stages 2, 3, and 4. Which means that they are in danger of further progress, and within 5 years they develop a complete inability to breathe and cannot continue to live independently and qualify for lung transplants. So definitely the risk of the development of changes is greater the longer we observe patients. And usually we get young or middle-aged patients, and we can observe them for longer. And as their lives progress, I think that we will see more and more patients like that in time. We have certain prognostic factors which are known to us, which indicate that patients are exposed to higher risk of developing this detrimental version of the disease. And I have listed in column 1 those factors which give us negative prognosis. Over 40 years of age, black race, usually female sex, or higher stage at the moment of diagnosis. Then presence of certain neutrophils in the bulb fluid, and definitely encroachment on other organs apart from lungs indicates a more severe progress of the disease. And what are the complications and consequences of sarcoidosis? Definitely the formation of granulomas may go in 2 directions, and definitely if we would like to avoid the formation of fibrotic lesions, and fibrotic lesions are the most frequent reason of death in sarcoidosis patients. And coming back to the data, the latest data, we see that across all patients, about 50% require systemic treatment. And mortality in multi-annual mortality is between 4 and 8% in developed countries, and definitely the fibrotic changes lead to lung dysfunctions and respiratory dysfunctions, and only 1/4, 25% of patients may not require treatment eventually. The 3/4 will definitely need to be treated. And definitely once they reach more advanced stages, so in 75%, some kind of treatment should be applied. And from the clinical point of view, what kind of therapeutic options we have on hand and whether we are satisfied with them. Let me refer to this very recent document of the European Respiratory Society, which includes certain recommendations related to sarcoidosis treatment. And experts, authors of that journal draw our attention to the fact that the decision of treatment should take into consideration 2 important factors: the risk for death of organ failure, but also the impairment of the quality of life. And we see that sarcoidosis patients show certain phenomenon related to the quality of life, the kind of malaise and weariness, which is related to the degree in which the respiratory system has been affected. So the fibrotic changes definitely produce such symptoms, but patients in stage 1 show different symptoms, such as pain in joints and other unspecific aches. And now a handful of information regarding this fatigue syndrome, which is present in sarcoidosis, and patients draw attention to the fact that they have to fight against this fatigue on the daily basis. And this is the current algorithm for the treatment, and we have all the therapeutic options available currently in blue, in light blue color marked. So we have a certain escalation of treatment from observation and leaving patients under control of the medical center. So that's the stage at which we simply monitor the progression of disease on the basis of radiological exams, but in further stages we start systemic treatment with glucocorticosteroids and immunosuppressant and other drugs which are second line or third line treatments. That is already my slide, which shows the therapeutic possibilities that we currently have on hand. So I'd like to draw attention before I finish to the fact that the efficacy of the drugs can only reach a certain level, but the administration has to be continued for many months. So between 6 and 12 months for steroids. Usually, however, we extend it up to 18 months, and that produces adverse effects. That is a group of drugs that probably causes the largest number of such adverse effects. And for this reason, when you look at the arrow leading to the second square, we have this important point: steroid-sparing agents, immunosuppressant, which may partly supplement the action of corticosteroids. However, immunosuppressant activities also affects the activity of the immune system and may lead to various other consequences and infections of respiratory systems, opportunistic pathogens present in the lungs. And my last slide, before I leave you, I have listed all the drugs that we have available at the moment. And please note that in the last and penultimate column, we have the information regarding the monitoring and some comments, and we can already see that there is a number of adverse effects and complications that are possible. Well, in my center, we have several dozen such patients under our supervision, and definitely we are very much interested in the studies related to their condition. We've been monitoring them and following the new developments for over 6 years now. And recently we have seen the publication related to the role of KITE1 as the marker of that disease. And since 2017, I've been following the development of the OATD01. So I really count on further progress of the studies and making this molecule available to patients. And hopefully the studies to come will confirm the efficacy of the drug, and the outlooks for the deployment and application in sarcoidosis is very seriously bright. Thank you for your attention.
Thank you, Rafał. Thank you, Professor.
So one question we've had internally for a very long time, and that's been asked more recently by potential partners and analysts alike, is there a market for a novel molecule in sarcoidosis? So we conducted an opportunity analysis, and for that we commissioned a consulting company specializing in pharmacoeconomics called Sightline, and we requested two things. First was to assess the current treatment paradigm, the unmet needs, and how the doctors they interview see OATD01 being used in practice, as well as based on its current product profile and expected properties, where could OATD01 be positioned price-wise. We wanted to understand what were the treatment goals and expectations, and what do the KOL, the key opinion leaders, give to their patients, and whether the available therapies are satisfactory or not. And for the pricing considerations, we wanted to identify the drivers and barriers to the uptake of the product, and for which patient OATD01 would be most suitable. And of course, finally, set a potential price for the yearly treatment with OATD01. So the study consisted of interviews, 45 to 60-minute interviews with key opinion leaders and payers from different countries, from China, from the US, from Europe, from the United Kingdom. For the key opinion leaders, we asked Citeline to confirm that these doctors were treating sarcoidosis patients and that they had prior clinical trial experience. And please note here that the individuals that were interviewed are different from the key opinion leaders that are already advising us. So some of the conclusions of this study are sensitive in nature, and therefore will not be sharing them here, but I will detail a number of salient facts. The KOL and the payers that were interviewed are not entirely satisfied with the current treatment options. And the common message is that there is a real need for safer and efficacious treatment that could halt disease progression while still being cost effective. And also some patients do not respond to the existing therapeutic arsenal. And with the current options, the sarcoidosis manifestations are inadequately managed. So it's obvious from their feedback that they are waiting for new therapies that can offer safe and effective substitutes to steroids to slow down and even stop the disease. And when they were presented with a target product profile, and based on the current data that is already available, the key opinion leader declared that they would propose OATD01 to 40% of the patients that they are treating. And they saw the route and regimen, oral, once a day, as being very strong attributes. The fact that they could replace steroids, therefore eliciting less side effects, that there were no drug-drug interaction in the studies that were conducted, and together with promising in vivo efficacy in granuloma reduction, were also seen as major strengths for OATD01. If the safety and the efficacy are confirmed during the clinical trials, another 35% of additional prescriptions could be made, and up to 75% of the patients that these KOLs see in their practice would be proposed the treatment. As it's been told already, currently the global sarcoidosis market consists mainly of steroids as a first intention, together with other immunosuppressive drugs from the 80s that are being used off-label and are not approved for the use in sarcoidosis, and these drugs are inexpensive. However, as we saw, these are by no means the best options for the patients, and we expect a rapid switch to better treatment when they become available. The market is therefore it is likely to completely change in the coming years. There is little competition as far as products that are purposely developed for sarcoidosis and not just repurposed, but the two most advanced molecules are namilumab. It's an antibody, monoclonal antibody, targets granulocyte macrophage colony stimulating factors, and it's currently in phase 2 from Kinevant. And there's efzofitimod, which is a phase 3, a selective modulator of NRP2, also administered IV from aTyr Pharma. Consolidating the information that we got from different sources, from Citeline, from other available analysis, and from our own forecasts, we have estimated that the value of a disease-modifying treatment could be about $1.5 billion a year at maturity. And this was confirmed in a recent casual discussion we had with an executive from a company with interests in sarcoidosis. We also believe that due to the complexity of the disease, several molecules would be combined in certain patient segments. Based on epidemiological data and treatment algorithms from different countries, we have assessed the treatment journey of 370,000 patients with diagnosed pulmonary sarcoidosis in the major market, excluding China here. And if our expectations of efficacy are confirmed in the clinic, the target population in the major market is about 150 to 200,000 patients that could be treated with OATD01. And as exemplified in the KOL interviews, there is a core population of patients that are currently receiving oral corticosteroids and immunosuppressants from which the healthcare providers would make a switch, and an upside in patients with the risk of progressive disease that are currently receiving, again, immunosuppressants and TNF-alpha. I would like to emphasize here that these are projections and that the target population can only be confirmed once we obtain readouts from the clinical studies.
So we're ready to summarize our presentation on the chitinase inhibitors and OATD01 with its treatment potential. And as you've heard, our commitment to solving the unmet medical needs of patients with interstitial lung diseases will start with sarcoidosis. We're confident of the drug safety profile after almost 130 healthy volunteers have received the drug. And the innovative clinical trial design that Samson described with its novel biomarker-driven endpoints, especially the imaging endpoints, promise effective recruitment of patients and meaningful results after a relatively short duration of the study. However, first and foremost, from the point of view of our company and Molecure, the planned phase 2 trial in sarcoidosis is envisioned to demonstrate the clinical proof of concept for the role of KITE1 inhibition as the biological target and as a key element to provide disease-modifying treatment for illnesses where chronic inflammation leads to tissue remodeling and damage. And we see that as a sort of universal key to open many doors to treatment of diseases with this similar etiology, and other organs have been mentioned, such as NASH in the liver or liver fibrosis, as well as inflammatory bowel disease in the intestine, which has not been mentioned in the presentation, but is also another option that could be pursued. So now, do we have questions after D02?
Okay. We do have questions right now. Thank you very much. Great. We are almost perfect with time. And now we would like to move to Q&A. Please type the questions referring to the topics already covered in this section, that is OATD01. I'm taking the first, reading out the first question. Okay, good morning. A question for Samson Fung, or perhaps Professor Krenke. Do you consider recruiting process for phase 2 in OATD01 as a challenge, bearing in mind that sarcoidosis is a rare disease?
I can take this question. Of course, the patient population is mainly that we are currently targeting with our phase 2 studies will be an outpatient population rather than a hospital-based population. That is a challenge. However, there are certain measurements that we can take. We are currently in discussions to file a media campaign via social media in order to create the awareness amongst patients. We would go via the patient groups or via the respective sarcoidosis foundations in the respective countries in order to make the pulmonologists, the GPs, but also the patients aware that there is a study ongoing that would provide an opportunity for the earlier patients to go to receive a potentially effective new treatment. So we are confident that we will be successful in recruiting the patients in that period of time that we are currently targeting.
Thank you. And a second question from the same person. What will be the earliest moment in time that you could hopefully see that OATD-01 actually works the way you expect in human, given that first patient, first visit will take place in third quarter 2023? Do you expect there may be a chance to include other indications in OATD-01? If so, when?
Well, I would, as a clinical developer, I would say, first of all, we have to complete our study, which means we have around 90 patients. It's a double-blinded randomized study, so we will only see conclusive results after the last patient has completed his 3-month treatment or 12-week treatment. Then we will be able to unblind the data. And then also to publish the data in the clinical study report or in peer-reviewed journals and so on. And only then we will, of course, know whether the proof of concept is achieved. And this would open, of course, then the discussions. In the meantime, we can, of course, have potential discussions, but only then we will really know on whether the compound is effective, how effective it is, on how safe it is, and then there, of course, is an opening for going into clinical trials in other indications. If that's the question that you were asking.
And
Yeah.
if I may add just one compliment. As Molecure, we will want to complete the sarcoidosis trial before engaging into anything else, for sure. But does not mean that through partnering, we will not be able to conduct in parallel studies in other diseases, in other organs. These things do happen. You can have a partner that takes in another indications and then take the rights for all indications later on, but wants just to make a proof of concept or a proof of principle in a disease in another organ.
Thank you. Another question. What in particular will you be looking for in the sarcoidosis clinical trials to support the commencement of development in NASH?
Do you want to take it or?
Can I?
Sure.
Of course, mode of action.
I can start with what do we see in common and what we will learn from the sarcoidosis trial, which will be then useful for the NASH. So first of all, as Samson has mentioned, the PET-CT scanning will be an information about the metabolic activity of the granulomas. And we will determine whether these granulomas are less active by the PET-CT scan information. The same type of information would be informative for our target cells in the NASH. And therefore, as you know, it's a metabolic disease, and this type of activation of immune cells that leads to the chronic inflammation, you know, 2 different organs, but we believe similar mechanisms based on our preclinical information and data.
Okay, thank you. Yeah, I think that's okay. Another one, could you elaborate on the quality of life measurements that will be included in OATD-01 second phase trial? Will they include symptoms presented by Professor Krenke?
Yes, the quality of life questionnaire that I mentioned, it's called the King's Sarcoidosis questionnaire, is a very well accepted. It's the best accepted quality of life questionnaire in this sarcoidosis segment. There are some others around that are not as well accepted. There are some around that are relatively simple, but they are, for example, consisting of 5 questions. That is too simple for us. And We have also been asked or requested by both authorities, the FDA as well as the EMA, in their advice to include some quality of life questionnaire. So of course, since this is becoming standard, we obviously choose the one that is the most accepted one.
Thank you. I think we have got time for one more question. This one will be asked in Polish. This one has been written down in Polish. Czy liczba 80 do 100
The number
pacjentów
of 80 up to 100 patients, will that be sufficient as proof of concept for the new target and the new activity mechanisms involving chitinase?
The answer is yes. At least, of course, there's always some uncertainties for the future, but according to the advice that we have received from our panel of key opinion leaders, you have seen the panel of international key opinion leaders from Europe and the US, but also from extensive discussions with nuclear medicine specialists and radiologists as well as statisticians, they are convinced that this will be sufficient. You have to please keep in mind that usually the primary endpoint for such studies has always been the clinical improvement. For the clinical improvement, 3 months of treatment will likely not be enough. But that's why we picked the more modern primary endpoint as the change in PET CT scan, which is the most modern endpoint, and there is quite some literature to demonstrate that PET CT scan will be likely be the best method for assessment of such diseases in the future.
Okay, great, thank you. Let's now move with part 2 about OATD02. I'm giving the floor back to Marcin Szumowski.
Thank you. So no break. A break only comes after the OATD02. So now it's time to switch from inflammation-driven fibrotic diseases to immuno-oncology. And that part of the pipeline is led by OATD02, our other clinical stage molecule. Can I get this? Okay. Due to its ability to stimulate the immune response, OATD02 can be addressed to a very broad range of cancers. And because of its other ability to inhibit the activity of both isoforms of arginase, arginase 1, which is extracellular, and arginase 2, which is intracellular, it can evoke 2 different mechanisms to fight the cancer cells. Arginase as a protein has been validated in clinical trials as a target in oncology, but the compound tested so far, which is an arginase 1 inhibitor from Calithera Insight, has demonstrated suboptimal efficacy. OATD02, through its superior molecule profile and dual activity on both isoforms of arginase, can be the first one to show and confirm both safety and efficacy in cancer patients, especially when combined with widely accepted and very successful checkpoint inhibitors. So there is competition, but it's not very large, and there's an increasing number of scientific publications that show the relevance and importance of arginase 2 as the relevant target in cancer treatment. The unique profile of OATD02 and its superior drug-like properties and characteristics are the differentiating factor of our compound versus competitions, and Zbyszek, in his part of the scientific presentation on D02, will elucidate that subject further. So in terms of the timelines, the adaptive phase 1 trial design, to be later described by Samson, should enable us to efficiently find the dose to be potentially effective and used in further efficacy studies. The main goal of the study is to demonstrate safety and tolerability of OATD02, but as in most cancer trials, we will also be observing markers and signs of efficacy that's because it's dosed to patients. The phase 1 study will take approximately 18 months. The first patients will receive the drug in the first quarter of next year, as early as possible after Christmas. And we expect to have the final results or the end of the study in the second half of 2024. And now I would like to turn the floor to Zbyszek and talk about the mechanism of action.
Yeah, thank you very much, Marcin. And let me now briefly familiarize you with our molecule and how it works. So again, as Marcin mentioned, this is the first in class dual inhibitor for Arch1 and Arch2, and that makes a difference because we believe this is the only drug that can address properly inhibition of arginase biology. I'm gonna go over that molecule, and here are some highlights of it, how effective it is in cancer therapy, in monotherapy and in combination, its drug-like properties, of course, protection by the patent and our idea to which specific cancer to go to. I would like to start with explaining a little bit the mechanisms of action, which is very important to understand in drug design, because then it can clearly choose a proper indication and give assurance of how the drug works. So it is important to start with this dual mechanism. So we have a situation that in a tumor microenvironment there are immunosuppressive cells, myeloid-derived suppressor cells and Tregs as an example. Myeloid-derived suppressor cells secrete arginase 1, which then inhibits effector cells, specifically T cells, which are needed and important for tumor killing. Arginase 2, this is an intracellular enzyme, and Tregs, another type of immunosuppressive cells, depend on it. At the same time, recent literature is suggesting that lots of tumors choose to change their metabolism to depend on arginase 2, and that's how they live and proliferate and overgrow in the environment. Importantly, tumors are also known to secrete arginase, so the effector cells, which we all need to kill tumor, are being dampened from both sides, immunosuppressive cells and tumor, by arginase. And what happens when we give OATD02? In a nutshell, we have the effector cells which are free to fulfill their function, which is to effectively kill tumor cells. So OATD02 is blocking immunosuppressive cells, and so they can no longer inhibit effector cells, our own immune response to kill the tumor. This is very important because this is a switch in the oncology field when we realize that immunosuppressive and immunomodulatory approach it's something that scientists believe has the highest chances of fighting tumor. Importantly, we also have a direct effect of the drug on our cancer cells, because, as I mentioned previously, lots of cancer overexpress Arch2 and their metabolism depend on it. And now I would like to back up what I said with preclinical data. So first of all, we have a compound that in a colorectal cancer model works nicely in a dose-dependent manner. So we see how increasing the dose is reducing the tumor growth. Because of its excellent drug-like properties, we can also observe the concentration of the drug in the tumor, so it reaches where it has to be to fulfill its function, to work. So the drug is in the tumor, and arginine levels, which is our PD marker, are dose-dependently changed as well. So in other words, we know that the tumors are smaller, and we know that the drug reaches the tumor microenvironment and is improving the immune response, which results in inhibited tumor growth. And another important aspect in oncology is how a drug behaves in a combination with checkpoint inhibitors. Checkpoint inhibitors, in our case, we have used anti-PD-L1 antibody, and we see an impressive tumor reduction by 78%, which is very reassuring for the future combination therapy in patients. We have also tried to use a triple combination therapy with another drug, an IDO inhibitor, pacadostat. This is something that Calithera has done, and we wanted to see how it would work in our hands, how effective it would be. You can see that our drug, given on its own, is reducing the tumor. In a combination with antibodies, is doing it in a combination with epidostat is reducing even farther. But when we have a triple therapy, it's an impressive 80% reduction. Some of the tumor growth was basically regressed, which is an excellent result to have in this type of model. We work, of course, in collaboration with different places to get the data, and this is a collaboration with the Nensky Institute in a very aggressive glioma model of cancer. We have observed here very nicely that our drug works here based on this imaging on its own in a monotherapy, but also in a combination with the antibody, where basically mice were almost freed from any cancer. Importantly, as we all know, the biomarker field is quite important in drug design, and the correlation here is important for the clinicians to predict. The CCL5 is a chemokine which is driving cancer, and we have shown that our drug is inhibiting RANTES and going down to very low levels in a combination therapy. So to summarize, the OATD02 has shown excellent results in the preclinical studies in different types of cancer. I showed you colorectal cancer, but we have also observed these differences in different types of cancer. And it works in a combination with the checkpoint inhibitors such as PD-1 and PD-L1 antibodies, and other drugs such as metabolic disruption drugs like IDO inhibitor, and in even aggressive models of cancer such as RENCA, kidney cancer, or glioma, or model of glioma. And here is a table that summarizes what we have and what was shown by Calithera. So because we have ARCH2 inhibition, we can affect cells, not just extracellular arginase, so intracellular, and that makes a difference when we want to talk about immunoregulation, about specific effects on Tregs or tumor-associated fibroblasts, which also have ARCH2 expression, and also a direct effect on cells. As Marcin mentioned, recent literature is very clear about the role of arginase 2 in the mitochondrial arginase 2 in the cell metabolism. We know that we affect it with our compound as the only component. that results in a high efficacy in both syngeneic models when we have the immune response element, and in a xenograft model when we look specifically at the effect on cancer cells. And below are drug-like properties which are also superior to the competition. And what we want to do next with our compound, I'm gonna hand over and ask Samson to carry on.
Yes, before I come to our clinical study that we are about to start, I would like to introduce to you Professor Schillig. Professor Schillig is the head of the Department of Clinical Oncology and Chemotherapy of the European Health Center in Otwock. He's also president for the Foundation of Experimental and Clinical Oncology and member of the Polish Society of Oncology. His main scientific interest concentrates on hematology oncology and clinical oncology. He's been a principal investigator in more than 100 clinical trials for a variety of solid tumors and lymphoma, and he's author of more than 250 scientific papers in peer-reviewed respected journals like the New England Journal of Medicine and the like. Professor Schillig, it's my pleasure.
Okay. So good afternoon to everybody, and the aim of my talk is just to give you a view of the situation in Poland, speaking about the morbidity and mortality of cancer. So we have a lot of problems, I mean, especially in nowadays, because of mainly of politics. So from one side, we have the epidemiological situation, increasing number of cancer cases in Poland, and from the other side, we have still the problems with reimbursement of the novel therapies, access to novel technologies, and also the typically human problems. I mean, limited number of oncologists which are, in service right now in Poland. So from one side, we have also the problem with immunotherapies, such, speaking about the checkpoint inhibitors. And the statement in here that kind of treatment had increased the responses and survival is only a partly of truth, because some of them, they are used in Poland with limited indications in specific cancer types. So we have the problem combining them with tyrosine kinase inhibitors. The problem is, for example, the renal cell cancer, where we have a possibility to use the combination of immunotherapies, but we do have a limit in case of combining them with tyrosine kinase inhibitors. So we know that approximately a quarter of patients that do respond to checkpoint inhibitors, but still we have the problems with resistance to the treatment and choosing the proper combination just to improve the efficacy of treatment. So may I have the next slide? That we have some of the data presented that we have a decline in deaths. I don't know which year these are the data, probably 2019. And this is a part of the truth. Today we are in 2022, and we have 3 years time of COVID. So we do expect increased number, and we do observe increased number of highly advanced malignancies in comparison to 2019. And probably strongly increased number of novel cases. So speaking about which type of cancer creates a clinical problem right now, at first we have to speak about the pancreatic ductal carcinoma. Even using modern kind of chemo, like a combination of FOLFIRINOX, which consists of 3 different cytostatic drugs, the survival rates of those patients do not exceed 2 years. So still, it's a real clinical problem. We do not see here glioblastoma. And in case of glioblastoma, practically since 40 years, we do not have any novel therapies which can be more efficient than temozolomide. Then we have metastatic colorectal cancer, which is effective in approximately 15 to 20% of our subpopulation, including those with MSI high and dMMR positive. Serous ovarian cancer, so where the immunotherapy is still not the standard of care, and we do not have any data which can support efficacy of this kind of therapy. And finally, RCC, we are using mainly tyrosine kinase inhibitors. Speaking about the ICIs and limited efficacy is still the problem, because there is, as I mentioned before, there is no problem combining ICIs, but there is still a problem about availability combining the ICIs with TKIs. May I have a next? So what we do have the situation of oncology in Poland, according to National Cancer Registry, and the data we do have from year 2019. So it's the second cause of death in Poland, mainly among the young and middle-aged people between 25 and 64, and 170,000 novel diagnosed, and more 100,000 people who died because of cancer. And the numbers, and as you see, is the balance among the cases between men and women. So speaking about the slight increase in the cancer cases is only, close to 2,000 in both sides. So it's not, and to me, it's surprising, because the difference between 2019 and 2000, as I do remember, 12 or 14, is more than 30,000 cases. So it doesn't reflect the real speed of detecting novel cases. We will see what will happen after these 3 years of COVID, and I will be not surprised if the number will be higher than 180. So what is of the particular concern is the impact of smoking. So there is a trend of lung cancer among the female in 2019, and the number of women who died as a result of lung cancer exceeded the number of women who died from breast cancer. It's not surprising. The problem is detecting both of the types of cancer. Usually the lung cancer is detected in very late stage. Only 5 to 10% of lung cancer detected cases we are able to operate and to offer the radical treatment, contrary to the breast cancer. There is most of the cases are detected in the really first phases of the tumor development. It is possibly in most of the cases the radical treatment. There is the difference, and probably the mechanism of differences in especially analyzing the number of deaths. May I have the next one? So the most common types of cancer among men is the prostate cancer, is more than 20%, the lung cancer. The second leading is 27% of deaths. And for almost 15 years, we do observe a decrease in incidence and mortality, probably associated with a decrease in percentage of male smokers in recent decades. Speaking about the colorectal, and as the third place, 8% of cases, and also we observe increasing trend of morbidity while stabilizing the mortality. Among the women, we do have at first the leading cancers of breast, lung, and colorectal. The incidence of breast cancer, which is, dominant among women, is, steadily increasing in the last 50 years. But what we do observe, and what we have to be really grateful to women organizations who, since more than 25 years, start to really effective and nicely performed campaign fighting with the breast cancer. And it's not only because of the state politics, but also about the social support for such a fight against the cancer. So the lung cancer, it remains to be the first cause of death among women, is close to 18%. And as a third, we do observe the increasing number of the colorectal cancer, which is also typical for also most of the European and globally. Please, the next. So, speaking about the treatment, as I mentioned before, pancreatic cancer is still a challenge, and the number of patients who really survive more than 5 years is only 10%, and those with 5 years survival is only 20%. So still we need another studies and other compounds targeting different targets than we do have today, just to increase the efficacy of the treatment. The another problem is the colorectal cancer, and still as the first and the second line, we do have a standard chemo, which is used by us since 20-25 years. The immunotherapy, the checkpoint inhibitors, still, we don't have any evidence of efficacy of those treatment, and we are looking for the novel treatment. Same when speaking about, for example, about the pancreatics, about the glioblastoma, which is pretty rare, but is the problem of very young people. May I have a next one? So next is the ovarian. I spoke already, and RCC. So it's a lot of expectations, but speaking about the increasing the efficacy of our treatment, we still are expecting novel drugs. And I will say since 5 years, we do not observe any progress speaking about the ovarian cancer. Much more, optimistic situation we have in case of RCC, because right now we have plenty of ICIs, we have plenty of TKIs, and I'm much more optimistic speaking about the efficacy in treatment of RCC. And next one. So that's all, from my side. So if you have any comments, any questions, I'm open to this. Thank you.
So thank you very much. I must just say that Professor Szczylik is the coordinator of the clinical trial that's about to start in the 3 centers in Poland, and we're very grateful for that and hope that our compound may help some of the patients that will take it.
Yes, thank you so much, Professor Szczylik, in setting the grounds for for our clinical study. As Professor Schillig pointed out, the immune checkpoint inhibitors have been quite applauded as a new treatment modality. However, they are only effective in a smaller portion of patients, actually far below 50% in some indications. As shown, it's only around 25 to 30% of patients. So there is still a huge unmet medical need for effective treatments. Now I would like to focus your attention on the upcoming phase 1 first-in-human study with OATD-02 that we are about to start in Poland. It's a few weeks that we have been granted the approval or the permission to conduct the study. So this is already quite very good moment for us, and we do expect the first patient in beginning of the forthcoming year. Currently, we are already embarked on bringing the sites on board that will conduct the study. Now we will have the first dual arginase 1 and arginase 2 inhibitor. As you have heard, there is still a desperate need for effective treatments. Chemotherapy has its issues. Checkpoint inhibitors are effective, however, only in a small proportion of patients. And we are convinced that our drug O2 will contribute to this armamentarium of novel agents to complement checkpoint inhibitors, but even so, maybe eventually also in a single drug, although this is not to be expected. There is a favorable therapeutic window of O2 with respect to the safety and tolerability, and that's exactly what we are going to define now in the upcoming study. The basis for that is that we have a better infiltration of the tumor microenvironment, and that is one of the current issues to find drugs that are effective in that space. If proven safe and effective, then obviously a broad range of tumors will be available for the further clinical studies and for treatments if successful. To focus your view on the schedule of events, again, CTA was granted just a few weeks ago. We are currently activating the sites. First patient is expected early next year. It's not far away. This study is going to last for approximately 1.5 years, so it will be completed by in the second half of 2024, and obviously a few months later we will have the clinical study report and then can progress from the clinical study report. Next slide, please. This study, as in all first-in-human phase 1 studies, will be an open-label, single-arm study with escalating doses in monotherapy. So it will be our compound O2 will be the only drug. We will use a modern escalation design, which is called a Bayesian design, but I do not want to go into details on that design. But it's a very, very accepted modern design. We will test about 30 to 40 patients. That depends obviously on when we have met our recommended phase 2 dose. The patient population will be patients that are relapsed or refractory metastatic solid tumors, which means they will have had several treatments before and failed those treatments, meaning that the disease will have progressed a few times before they will be coming into our study. We focus on those studies that were also mentioned by Professor Schillig: colorectal cancer, ovarian cancer, pancreatic cancer, and renal cell cancer, where there is a high unmet need, but also there are a lot of patients concerned. The study will take place in 3 sites in Poland, in Warsaw, Otwock, and Bydgoszcz. And again, the study will take around 1.5 years. Next slide, please. The main objectives of the study, as in a classical phase 1 study, is safety and the tolerability of the drug. It's an oral treatment. And our target is to determine the maximum tolerated dose, and out of this, the recommended phase 2 dose. The recommended phase 2 dose is the dose that we will take into further clinical development. That may be the same as the maximum tolerated dose, or a dose which has the best risk-benefit ratio. Secondary outcomes comprise pharmacokinetics. We need to learn a little bit more of our drug in the patients, pharmacodynamic biomarkers, and of course, we would be looking for efficacy defined by the response rate of the tumors, and also looking for survival endpoints. And as said before, these data that we would generate out of these studies will inform the design of future clinical studies in the phase 2 setting. It can be those tumors that we test, but it may also be possible to go into other, like hematological malignancies, where we have effects as seen in the non-clinical program. Next slide, please. I think that concludes my slides.
Yes, so it's time to summarize the description of D02 and its potential as a first-in-class therapy to address a broad range of cancer patients. This novel therapy faces limited competition and has demonstrated efficacy in animal studies. The first patients will undergo treatment in Q1 of 23 en route to demonstrating safety and preliminary efficacy as a mono and combination therapy. So this is our target, and we're excited to start this trial as early next year as possible by enrolling patients. Do we have questions? Yes, we do have questions now.
Exactly, yes, we do have questions. The first question, could you please give us more details about the clinical trial scheme for OATD02, the estimated cost, for how long it will be administered to one patient? You also mentioned about the rollover study in your quarterly report. Why is this a separate study that will need a separate CTA if this is a continuation?
I can allude on that. Let's start with the rollover study first. In oncology, you're basically start giving the patient a drug and investigate a certain period of time, which we call DLT period. So it's dose-limiting toxicity period. This period is obviously has some time limitation. In general, it's something around 1 cycle. In our case, 1 cycle is 28 days. So our so-called DLT period, during which we will observe all safety events, is 28 days. If there is a so-called drug-limiting toxicity within those 28 days, then we have to take certain measures to protect the patients, which means that we have to add another few patients in that dose. Only if these patients are safe, then we are allowed to go to the next dose. Just imagine that the patient has a benefit. If a patient has a benefit, And that happens also in phase 1 studies, that the patient has a partial response or is stable in his disease, he's doing well, then you cannot withdraw the drug from the patient. That would be unethical. So if the patient has anyway, we will give the patients another 5 months. So the total duration for one patient will be 6 months. But after those 6 months, we would not withdraw drug from the patient if the patient has a benefit. This would definitely be unethical. Now, there's many ways to prolong giving the patient drug. You can do this as a kind of compassionate use. This is generally not favored by the European Union, by the EMA. You can offer to continue the study, but then the study may go on for a very, very long time, and we would not be able to analyze all the study data. And the third way, that's what we choose, that's a pretty common way to do it, is to roll over those patients who have a benefit on the same dose of drug into another protocol. By doing this, we can close or complete the original study and publish or use those results for discussions with the authorities, because then those patients who have a benefit will be then treated in the rollover protocol. So this is the usual regulatory pathway how to handle patients that are doing well. And your first question was your previous.
Okay, yes, it was about more details about the clinical trial scheme, the estimated cost, and for how long it will be administered.
Yeah, the trial scheme.
You've already given.
Usually, I have to go back to the classical scheme of a phase 1 study. This is what you read in the publications as 3+3 design, which means you start somewhere. You start with a dose. Usually it's the lowest dose, and the lowest dose is a dose that you generally do not expect any benefit for the patient, and hopefully also no major safety issues. So you usually have 3 patients in that dose. If there's no safety issue, then you can advance to the next dose. Then there is a scheme how to advance to the next dose. So in the Bayesian design that I explained earlier, there is the chance of having more patients at a dose which you believe or which you anticipate that is effective and safe. So usually you get 3, 3, 3, 3. And the Bayesian design offers the possibility to have 6 or 9 patients in the dose ranges where you still feel that it is safe, but expect efficacy. Obviously, this would be helpful to the patients as well, because you do not want to give patients a drug where you know or where you expect that there will be no efficacy. So that's a more modern design in order to allow patients to rather get the benefit. And the costs, of course, this is somewhat dependent on how many dose cohorts we will need. Generally, the costs for a phase 1 study is a couple of million euros, or the respective number in Polish zloty. It's 1 to 5, I think, I believe.
I can comment of what we have in the budget right now. So what we have in the budget is almost 11 million zlotys to run this trial. And of course, it can differ depending on how many patients and for how long go into a rollover study. But this includes the estimate of the patients that may roll over into the longer dosing of the compound. And out of that, I believe 4.5 million or 5 are still available from the grant funding that we have for this program.
Unfortunately, it's very hard to predict what happens in a patient. I mean, it's easier in an animal than in human beings. They may, as you can see, we have different tumor types, so the tumor type may also play a role. It can well happen that after the 3rd dose cohort, we have already hours our best dose, but it can also take a little longer. We generally, the general experience tells you it's something around 6 to 7 dose cohorts, but it can vary. I've seen studies that go up to 12 dose cohorts. That's not what we expect, but even that can happen, as I've seen recently in a study with a big pharmaceutical company. So you cannot always calculate this. But we have planned, at least in our budget, for to have enough dose cohorts, inclusive of the rollover study.
Thank you. You've covered that perfectly. There's another question. This one has been asked in Polish and has been addressed to Professor Szczylik, who, as I can see, has actually had to return to his duties right now. So maybe, Samson, I will translate that for you, so maybe you can take that question. The question is, how do you assess, in general, the quality of clinical trials conducted in oncology in Poland against those that are conducted in Western Europe or the United States?
Well, that's a very difficult question. Now,
sorry for that.
no worries. Poland has become, my vast experience rather comes from the US and from Western Europe, as I have not been for many, many years in Molecure, obviously. Nevertheless, during my times in the US and Western Europe, we have conducted a lot of studies where Polish sites were involved. And Poland, in the meantime, has become one of the very respected countries for clinical studies. The quality has tremendously improved, and in quite a few areas, Polish sites have become the mainstay or the most reliable sites for clinical studies in hematological malignancies as well as in solid tumors. So there's more and more sites being picked that are from Poland because of, number one, the rate of patient enrollment, number two, the quality of the personnel, and the quality, of course, the quality of the data, which is the most important one for the sites. So already starting studies in Poland is already pretty competitive now. Because a lot of Polish sites are involved in a significant number of studies out of the US, but also out of Western Europe, if that answers your question.
And as Professor Szczylik was explaining, the reimbursement scheme for anti-cancer drugs in Poland does not always benefit the patients, and therefore recruitment of patients with cancer is somewhat easier because they are willing to go on protocols, on clinical trials.
Okay, thank you for that. This was the last question in this section. So let's have a planned break now. You can either stay online or disconnect and log in again with the same link for the session starting at 3:40 p.m. or for our US guests at 9:40 Eastern Time. And yeah, see you in 13 minutes.
still with us. After a short break, we're going to move to the next part of the presentation. And as you can see in our vision, small molecules interacting with novel unexplored targets are a part of Molecure's DNA. And this novelty and unexplored targets have actually made this DNA lead us to RNA, which is going to be a part of the next presentation. And this is what we do, and this is what we excel in and want to continue building our leadership position in that space. And one of the small steps on the way to becoming recognized as a company that deals with RNA targets is Zbyszek's trip to Boston next week, where he will be presenting or actually running a workshop on RNA drug discovery with co-founder of Arrakis, who will be presenting alongside, and it's a big meeting in Boston that focuses strictly on small molecules interacting with RNA. But now we would like to briefly update you on our innovative post-translational and part of our early pipeline. In particular, we'll focus on the USP7 program, where we have generated some new and exciting data, as well as the pre-translational, which refers to the mRNA function modifying small molecules that prevent the translation of the pathological processes. So I'm turning this over to Zbyszek, and this is the part of the pipeline that he will be discussing.
Thank you. Thank you, Marcin. So let me first start with ubiquitination process. It is a post-translational modification of a protein that sends a signal for a protein to be degraded. And this is a process that is common for different pathways and specifically upregulated in cancers. And this modification, post-translational modification, gives different opportunities, therapeutic opportunities, which affect not just one pathway, not just one protein, but certain processes, such as life of different transcription factor and other very important functional proteins important for the biology, which is dysregulated in situations such as cancer. So the ubiquitination is a process that adds ubiquitin molecules to proteins, and that's a signal for a protein to be degraded, but there are different enzymes called deubiquitinases. And deubiquitinases are targets in our pipeline, and the most advanced is USP7, for which we have an inhibitor, which I am gonna explain about in the next couple of slides. Deubiquitinases, there is over 40 or maybe 50 of them. We learn more and more about their biology. It is a platform of post-translational modifications which we want to target in the future. OAT 4828 is our most advanced USP7 inhibitor. As you can see on this slide, mice treated with this compound have reduced tumor growth. The tumors are less necrotic, so less vasculature is around them, and they are smaller. That's the macroscopic look at it. Now, when we go into more details to understand what exactly our compound does, we learned that specifically cytotoxic CD8 cells are induced in the tumor site. It's more of them, and also systematically. More importantly, these cells have more, they're activated, as evidenced by granzyme and interferon gamma, both biomarkers of activation of immune response, anti-tumor response. So just as in the first part of the presentation when we talked about KITE1 and macrophages as our target cells, we learned that our USP7 inhibitor targets specifically CD8 cells. And what we wanted to do is to learn actually more about the function of these cells. So we know that they are more activated, we know that they have capacity to kill, but can they actually kill more effectively cancer cells? So what we did, and I'm going to spend a little time on it because this is a very impressive data which explains the mechanism of action. So what we did is we treated mice with our compound, after which we isolated splenocytes, which are basically a representation of blood, including T cells, and co-cultured them with cancer cells for 3 days. And what we observed is that without the presence of our compound, so a situation where the immune cells simply, a memory remembered the compound and then ex vivo acted more effectively in killing in a dose-dependent manner. As you can see here on the graph, so they were more effective in killing cancer cells, and that shows that our compound changed the phenotype of the cells functionally, and that's how we can explain why the tumors are smaller. We have also macroscopically observed that our compound increased survival of mice in a monotherapy, as you can see here, and obviously we tried it in a combination with antibodies because that's the standard way now to look at the immunomodulation and immunotherapy in cancer. We have observed very similar effects in a melanoma cancer model where we have in a pilot study observed an impressive TGI of 72% inhibition of tumor growth, and again we modulate CD8 cells, which numbers are increased, and CD4 cells are also activated, acting specifically on tumor. So that hold it true what I just showed you in details in 2 different models of cancer. Now this was the preclinical study. We have decided to look at the co-culture of primary human cells with human primary immune cells with cancer cells in a human system. So this is as close as we can get to human, I suppose, and mimic the environment. And what we have observed that in 2 different experiments, our compound has shown very promising effects. First of all, it downregulated VEGF. This is a new information for us, but VEGF is important for the vessel formation. That's how tumor tries to get all the nutrients into it by surrounding itself with the new blood vessels. Our compound has shown effectively inhibit that molecule, VEGF, which is driving new vessel formation. And importantly, we have verified rodent data in the human system. Namely, we saw an increase in interferon gamma, which is a cytokine, an interferon actually, which kills cells or is making, which kills cancer cells produced by T cells, and a granzyme B, which also helps for the killing. So the data that I showed you from the preclinical studies was verified in a human co-culture system. Another program in the early pipeline is the YKL40. It belongs to this chitinase family. We have a very good binder of the YKL40 with already optimized drug-like properties, and it's so far clean. By that I mean has no off-target activity. In the next year, with the help of international collaboration, we would like to learn more about the biology of that protein and of our compound to try to understand it better. We have also a program that is a license option agreement for molecules, a lead molecule and a group of molecules for a therapy in the fibrotic disorders. Our research in the next year will focus on optimizing these molecules and improve the in vivo effect. And now I wanted to talk a little bit more about our future, about what we are very excited about, and what Marcin already alluded to, which is a new way of drug design, which is targeting RNA, so pre-translation, without allowing proteins, detrimental proteins, to be translated. We are at this stage within this year, we have built a lot of expertise, and we have now a team of chemo and bioinformaticians and RNA biologists, and we involved chemists as well. So we are forming a core team that works on that platform, and I will just briefly describe how we look at it. So it's a situation where we know that proteins, specifically those that don't have enzymatic activity, are very often difficult to drug, and they are so-called undruggable targets. But apart from that, there are also different targets for which there are just biologics, which are expensive and need hospitalization, such as antibodies. And these were our target mRNA selection. So we have looked at the mRNAs for proteins that are undruggable or for which there are biologics in two different main indications: oncology and inflammation. That's where we have expertise. And we wanted, firstly, after finding these genes, we wanted to look if they have a structure. We use shape method to verify secondary structure with the help also of the bioinformatics tools. After that, we can then predict with the help of experimental setup, or simply with experiments, the 3D structure of such a RNA, for which we can then perform virtual screen and try to find molecules that would bind to it and change the life of that mRNA. And this is our pipeline at this moment. To jumpstart this program, we have initiated a collaboration with the International Institute and Professor Bujnicki group. So to be more specific, I wanted to tell you that we had initially 40 genes which we found attractive from the business perspective and from the biology perspective. So verified targets, no risk here, for which there is no drugs at the marker, small molecules. Out of 40, we have identified in 34 of them structures, and importantly, when we identify the structure, we wanted to make sure that this structure is functional, meaning it binds to a protein or microRNA which regulates it, and then a small molecule can disrupt that binding. And we ended up with the 3 fragments for 3 different mRNAs, and then we have verified in vitro, but also within the cell of interest, the structure. And now we are at the stage of the virtual screen, after which we will select molecules, and we have already started to set up assays within our group and within our group in biology, but also in collaboration with different institutes, to start screening of the compounds. It is important to mention that because of the novelty of that approach, at this stage of cellular activity proven, we can already, if we want to, make a deal, and there is already an interest to to buy this type of molecules in the market because of the novelty. Of course, we have the capacity within our company, which we have proven with these OATD01 and OATD02, to carry on with that project further if we decide to.
Okay, great. Yeah, we are heading for the Q&A session now. Or would you like to add anything else? Sorry.
No, I think Q&A is good now. So we will try to answer any questions remaining, and then we can summarize.
Okay, great. Then the first question: what are the differences and similarities in terms of mechanism of action between targeted protein degradation technology and the ubiquitinase inhibitors?
So that's probably PROTACs that somebody is referring to. And the difference is that we are using physiological and endogenous pathways of regulation of protein degradation, ubiquitination, which we believe has many advantages because we just introduce a small molecule which is PROTACs. You probably have some issues with whether it would be intracellular and so on, and with these pathways that we choose here, with the help of bioinformatics group, where we can exactly identify which ubiquitinases are expressed in which disease indication, with the help of crystal structures of these proteins that we can have, we can really directly go and there is also preclinical data with and some of the ubiquitinase are not the one that we work on, are in the clinic. So that's our approach, and I feel that the advantages is that you use endogenous or regulate endogenous pathways. If that answers the question.
Okay, thank you. I don't see a following question from that user, so it's I guess it's okay. Then another question regarding the ubiquitinases as well. What is the competition landscape in this area?
Maybe Nicolas can start, and I can then, if this is specifically about USP7. And if it's about others, I don't know.
So in terms of USP in general, there are some companies that have already put USP inhibitors in the clinic in South Korea and in Great Britain. 2 companies who have started, but it's very recent. I mean, the first USP1 in oncology patient was introduced just a year ago, and the next one was from Mission Therapeutic, and that was the USP30, if I remember correctly, in renal diseases, and that was introduced to the patients again in a phase 1. In March of this year. So only 2 USPs currently in the clinic. A few companies are working on USP, and if we're talking about USP7, for instance, we could count 3 companies that do actually have USP7 exemplified in their pipeline on their websites, but we believe that there may be a couple more. When we look at the patent landscape, when we look at who has been filing for new composition of matter in the last year or so, but we're still in a very good position, I think, with our compound, because with the USP7, no one is on the market, no one is in the clinic, certainly, and we have conducted head-to-head comparisons with what we believe to be the most advanced compound from a Californian company, and our compound is more efficacious while being 10 times less toxic than this tested compound. So we think that we are in a good position right now. We know of another British company who has a compound because they try to sell it to us, but it's probably less or as advanced as ours, but they don't have any plans to progress it on their own.
So yeah, from my perspective, there is some race that is going on, but we feel confident.
Okay, thank you. There's another question that regards your mRNA platform. Is the RNA stable in your compound? How many days? And what temperature of storage is required?
So that question is probably about mRNA vaccines or using oligonucleotides because, and then I'm sorry if I was not clear, we are not doing antisense or oligos. We are designing small molecules to target mRNA, to target untranslated regions on the 3' or most of the time or 5' of mRNA. So the stability of RNA here is not an issue because our compound, which we are producing, is a small molecule, just like for the regular protein targets, where proteins have structures and have binding pockets, just the same holds true in certain degree in mRNA, where mRNA folds has a secondary and a 3D structure, and these structures can have pockets to which a compound can bind. In that sense, the compounds that we are gonna be testing soon are not much different to the compounds used for the traditional protein research. So they are stable and they are gonna be designed as drugs, oral, and that's our approach. So that was maybe some misunderstanding, but yeah, the whole idea here is to target mRNA with small molecules.
So
yes, thank you.
The target
yeah, okay,
itself,
go on, please.
So the target itself is the mRNA. The mRNA is not the product, and the mRNA needs to be in a linear form in order to be read by the ribosomes and to be translated into a protein. And we want to prevent this translation. So when the RNA is in the cell, it falls and unfolds all the time, and before being read by the ribosomes, and we want to lock it in a stable conformation so that it cannot unfold and be read by the ribosome. So if the RNA is in a bundle, then you will not have the translation into the protein, and this is where we're acting. So the product is a small molecule, the target is the mRNA.
Okay, great. I think that's a very important explanation that you've just provided. So thank you for that. And the last question for now is as follows. When do you expect to seal the deal with Michigan?
Yeah, it's we're basically working on the best path forward because as you saw, the option period was extended because the results that we generated in this program were not allowing us to move forward with the compound optimization at this stage. So we're in discussions, and I think they should probably reach an agreement stage around either the end of the year or beginning of next year.
Okay, thank you. That was the last question. That concludes the presentation. Thank you for participating. I would like to turn the conference back over again to Marcin for the concluding remarks.
Yeah, so maybe if I have that slide flipping to. Okay, so maybe just before we conclude and close, I would like to describe how we see the near future. By near, I mean the next 2 to 3 years. So actually, we look with a lot of excitement towards these next years when we will continue to grow the company by progressing our 2 lead assets in clinical development to meaningful endpoints in both of the multi-center clinical studies. And this is a very important and meaningful time for the company, because this is actually the first time when we will have opportunity to treat patients with incurable diseases. So far, our compounds have only been tested in many healthy volunteers, but not in patients. And the proof of concept in OATD01 should definitely, as already mentioned, enable expansion into other diseases with unmet medical need, increasing the potential in the market for chitinase inhibitors in general. Confirming safety and tolerability of OATD02, on the other hand, should enable us to start phase 2 studies in combinations that were discussed today. We really see the role of our compound as sort of a tumor warmer, which in many cases, as evident from the preclinical data, enables the combination of the 2 different molecules reach a superior effect to either one working as a monotherapy. And during the same period, we are planning to nominate 2 additional clinical candidates to progress forward towards clinical development, 3 and 4 in order. And that will come from our the internal discovery pipeline or from in-licensing. And we will continue to explore high-value novel targets, both in the RNA space and in the protein space. So also within the next 2 years, we anticipate partnering at least one of our clinical assets while growing the value of the partnering potential of the earlier stage programs. This will obviously provide revenue and income for further pipeline expansion and longer asset progression, as well as strengthening and expanding our talented human resources that work on the science and development of these molecules. And last but not least, progress in the RNA platform and building really a leadership position in this novel approach in Europe. And this is this niche approach of small molecules working as a drug and changing the function of RNA. We should be able to generate promising drug-like molecules that can either be partnered at the early stage or developed further in collaboration and partnerships with larger companies. And we see mentioning Arrakis, they've been able to do both actually, and have been successful in doing that. This is in short the outlook for the next 2 to 3 years, and in essence, we are a team inspired by science and driven by world-class medicinal chemistry and biology, selecting promising but little explored targets with relevance in areas of many unmet medical needs. We have access to top talent from many Polish universities and research institutes, and we operate at a several-fold higher cost efficiency compared to some of our international competitors, for instance, in the USP7 space or any other space. And as a fully integrated biotechnology company with 2 first-in-class clinical stage assets, as well as the pre-translational and post-translational protein modification discovery engine, we can expect a several-fold value growth in the next 2 to 3 years. So with that, we would like to thank you for your participation. Thank you for your interest in our company, and foremost in the science that's generated here and transferred into products that can become drugs, disease-modifying drugs. And we look forward to the next years to prove that.
Okay, thank you, Marcin. Thank you, everybody who presented today for your comprehensive and insightful update. For full presentation slides, please visit the company's website and use an events section specifically. Also, the recordings of today's event will be made available to you within a couple of days at Molecure's YouTube channel. As Marcin said, we really appreciate your interest in Molecure and look forward to keeping you updated in the coming weeks. We encourage you to contact Investor Relations. So with this, please enjoy the rest of your day. And we would like to wish you and your families a very Merry Christmas time.
Yes, forgot that Christmas is coming. Yes, Merry Christmas to everyone, and hope to get some rest and new energy for the next year to come, with all its challenges.
Thank you very much.
Wszystkiego dobrego.
Thank you.
Dziękujemy.